My name is Luke Johnson, and I'm a trainer with Springs Recovery Connection. I wanted to welcome you to our opioid response training video. Before we get into everything, I want to tell you a personal story. So I grew up in Woodland Park, Colorado. I was always a really shy, introverted kid. Unless if I knew you well, then I couldn't stop talking. And I always grew up like judging myself, thinking about myself a lot. I would be worried in high school, like if I had sweat stains under my shirt, which would cause more sweat stains. I had acne, had to go on Accutane for that. And I was always just very, very self-critical. My junior year of high school, my family ended up fostering who I still call my little sister. And she lived in our family for about 9 months. And she filled this void that I always had, like this hole inside of me. And her and I became really, really close. Well, about 10 days after her second birthday, through a long story that I won't get into, we lost her. She went back with the family that was pretty abusive and the reason why we got her in the first place. And so fast forwarding a little bit, I graduated high school in 2007 and I was going to college. Well, I had experimented a little bit with drugs in high school. I actually took my ACTs high on Ambien. I didn't realize that it was ACT days that day, and I popped a pill and I show up and it's ACTs. And so I scored a 13 on it. And I decided to go to community college after I graduated, and I had to take an English class before I was allowed to take any other class. It was like a placement English class, just saying that I'm good enough at English to take a history class. And so since I was taking that, the only other class that I could take at the time was a computer class because they didn't require us to do any reading in that. And so I had like this 8-hour window in between classes, and I lived in Woodland Park, and my grandparents were down here, and I got really close with my papap, my dad's dad. And he was a Korean War vet, World War II vet, and he would tell me all these stories. He had really bad PTSD from what he had to do in the Korean War. And him and I grew really close. And that hole that I lost, or that hole that was filled from my little sister, came back obviously after she left. And he really helped fill that. Well, after my first semester of college, he passed away. And as he was about to pass away, I went to my grandma's house, and I helped her the night before we put him in the convalescent home. And I had to help her, help him go to the bathroom and stuff. And that hole came back. And so I raided their medicine cabinet, and I ended up using some codeine cough syrup. And it filled that hole again, and I didn't have to feel a lot of the pain that I grew up with. And so I decided that maybe this could be my next solution. And so my dad has always had pain issues, and he was prescribed methadone for his pain issues. And I started rating his medicine. I had no idea what I was doing at the time. I had no idea what methadone was. My family didn't know what methadone was. Even the doctors that told my dad about it, like he didn't even really realize what it was, or at least what he relayed to us about the medication. And it made me feel amazing. I started serving in a restaurant, and I noticed that my tips would go up. Tables liked to talk to me. They thought that I was very gregarious. They thought that I was charismatic, and I would have fun and laugh. And that hole wasn't there anymore, or at least I was numb to that hole. And so that led me down about like a 2 to 3 year stint of using methadone. And when it came time to quit, I went to a doctor. My family asked me to quit quite a few times, and I kept lying and manipulating to them because I was addicted. I didn't realize I was addicted because methadone is a unique substance that the withdrawal doesn't really happen until later, and the withdrawal is actually worse than most opioids out there, pretty much all opioids out there, really. So I went to a psychiatrist and I told him about what I was going through, and he said that I would be withdrawaled off of methadone in 5 days. So he gave me some, I think it was called Ristoril or something like that, some sort of benzodiazepine, and clonidine, which is a blood pressure medication. He said I'd be feeling better in 5 days. Well, the withdrawal didn't really hit until about 4 days into it. And I went through, it was the longest withdrawal I've ever been through. I went through it cold turkey, with the exception of those first 5 days that I had that medication. And I went through a 9-month withdrawal. 3 months into it, I could still not hold my bowels. I was defecating myself in my house alone while my family's at work. And it's the hardest thing I've ever been through. I was on the brink of insanity. Like that was my life. And so all the things that I learned through that process and over the years is what has gone into this training. You'll hear stories from other people in this training, and this training is about opioids and what they can do to you, and about different ways of getting out of that addiction, different medicines that we could take to maybe help us if that's the right thing for us. This training is about solutions, and this training is about education. Fortunately, opioids are one of the few medications or drugs that there are medication-supported recovery for. And hopefully through this training, we don't lose as many people as we've lost, with people being armed with the right knowledge. So that's to preface what this training is about. So let's get into it. Have you ever met somebody, or you yourself, have you ever met somebody that has neurological problems? Maybe schizophrenia, maybe bipolar disorder, chronic depression, ADHD. What happens when these people are on the correct medication? Obviously, their quality of life is better. What's going on inside their brain is neurological problems. And many times they're related to something called neurotransmitters. Neurotransmitters, there's over 40 of them in your body. And these are the messengers that go between neurons, and it's how your brain communicates with itself, with the rest of your body. Well, when it comes to recreational drugs and substances that people use, those mimic neurotransmitters. That's how they work. That's why your body is able to take them on and hear the signal that they're trying to express. And when it comes to recreational drugs, that's what gets you high. Opiates and opioids mimic a neurotransmitter called endorphins. And endorphins are there to help us when we have pain. Basically what happens when you have pain is you have neurons communicating to your brain that, oh, Luke just cut himself. And so an endorphin will go in and they'll try to block some of those pain signals, and they also make you feel good to help soothe that pain that you're going through. When people run, they produce endorphins. When they laugh, they produce endorphins. When they eat food, have sex, when a mother looks at her child or grandbaby, endorphins are produced. These things are designed to make us feel good. They help with stress, and they help with pain, and emotional pain as well, because pain is pain, regardless of where it comes from. And so when you have a healthy brain, these neurotransmitters come in at the appropriate time. There's enough of them produced to manage day-to-day functions. Well, what happens when somebody starts taking synthetic, or we'll call it synthetic endorphins? Those are things that we call opiates and opioids. There are two different classifications, I guess you could call it. Opiates are anything that comes from a poppy flower. So this is morphine, codeine, thebaine. Thebaine is the strongest one. Morphine is second strongest. Codeine is the third. And then anything that is an opioid is synthetic. Comes from different science labs and stuff. And then there's also a thing called kratom that you can buy over the counter. That's a naturally occurring substance related to a coffee plant that is also an opioid. So when people take these for a long time, it starts messing with the brain, and the brain isn't able to produce the correct amount of endorphins. And so this is what causes dependence and withdrawal. I want to go into the difference between a dependence and addiction, because we use pain medication in surgeries. Pain medication is huge, and as we'll get into the history of this opioid epidemic that we're in, we'll start seeing how our culture has been based around pain medication. So what is dependence? Dependence is when your body becomes dependent upon this substance because, in opioids anyways, because you're not producing endorphins anymore because they're already there, they're fake. And they're stronger than the endorphins that your body normally creates. Opiates are. And then there's a thing called tolerance that can happen. And so what tolerance is where you get to a point where the current amount of opioids that you're taking doesn't cover the issue anymore. It doesn't cover the pain, and your brain isn't able to function normally. So people start developing a tolerance to how much they're taking, and they need to take more to produce a desired result. And then finally, there's the other side of dependence, which is withdrawal. And so what withdrawal is when you either decrease a substance, whatever opioid you're taking, or you just quit entirely, and your body goes through a process of dysfunction because there's no endorphins and there's no, not the correct amount of opioids or opiates in the system anymore. And that's what causes what we call withdrawal. So there is another thing as well that happens when people might just have an opioid dependence, not an addiction. And this is called opioid-induced hyperalgesia. That's a big word that you don't need to remember. However, there is documentation of this all the way back to the 1800s when opioids and stuff were first used in medicine. And what this is where people have a heightened response to pain. They feel pain stronger because they've been on opioids for a long time. It's kind of a weird thing that happens to the body. And as we'll see in our story from Bob later, he had opioid-induced hyperalgesia, and his pain was stronger, so he thought he needed more opiates. Doesn't mean that he's in an addiction yet. However, this is a thing that can happen. A lot of people that are on opioids, sometimes they can't handle spicy food anymore because the intensity of the pain that comes from that. So now that we've gone over that, what is addiction? According to the DSM-5, there's 11 criteria that one must meet to be called an addict. Like, you need to meet either 2 or 3 of these over the course of a 12-month period to have a mild substance use disorder or addiction. If you meet 4 to 5, that's considered a moderate substance use disorder or addiction. And if you meet 6 or more of these criteria, that's considered severe. The criteria are, I'll read them off to you: hazardous use, social or interpersonal problems related to use, neglected major roles to use, withdrawal, tolerance, used larger amounts longer, repeated attempts to control use or quit, a lot of time spent using, physical or psychological problems related to use, activities given up to use, and craving. For me, in my own personal story, that's life, right? It's funny that that's considered severe to me because that's just day to day when my active substance use disorder was going on. So I want to highlight that for you because just because somebody is dependent upon a medication that might be prescribed to them, that doesn't mean that they're an addict. And they could still go on some medication-supported recovery or medication-assisted treatment, as I would call it, in that occurrence of dependence, to help them get off of that opioid. Let's get into what separates opioid drugs from one another. Some are more dangerous than others, and some have more harm involved when trying to quit using them versus others, as I talked about in my story originally. So one thing that separates them is strength. Every opioid drug is different from one another in how strong it is on your body and how your body reacts to it. And for somebody that is seeking a high, that strength induces a stronger or lesser high. The next one is half-life. So how long this drug is actually active in your system. That's all a half-life means, is how long it takes after I ingest this drug for this drug to start reducing to half of the amount that was in my body as my body metabolizes it from the first time I used it. Another one that's big is solubility. There's water-soluble drugs, and then there's fat-soluble drugs. And these are a huge thing because they relate to withdrawal. So a water-soluble drug such as like heroin or fentanyl or something like that, you can go through that withdrawal period in the course of 7 to 10 days. When it comes to something like methadone, this drug absorbs into your fat cells. And so let's think about the fattiest places on our body. If you're a male, your testicles. If you're a female, your ovaries, your reproductive organs. Your brain is highly fatty. And then your bone marrow inside of your bones. Well, what does that do for us? A lot of our hormones are created inside of our reproductive organs in our brains. And so a male that's utilizing a drug that's in his fat cells, such as methadone, that's going to start reducing that testosterone. It's not uncommon for people on methadone to lose hair on their legs. It happened to me while I was on it. And when I quit using methadone, then I have this really extended withdrawal because it's inside of my bones. It's inside of all the fat in my body. And so even though it might not register on a urine test, my body is still trying to get it out of my system. And so that extends that withdrawal for a really long time. We'll talk about different kinds of withdrawal later, but there are 3 different kinds that you could be experiencing from opioids. Another one is the way it's used. Opiates can be used on the skin. There's transdermal, so something like fentanyl. There's cases where cops have gone in and seized drugs on an arrest, and they overdose just by touching a bag because the fentanyl is absorbed through the bag and through the skin. There are ways where people inject it. There's ingesting it through your mouth. Some people will snort it. Some people might drink it. Then there's also sublingual forms as well that people put under their tongue. And then finally there's smoking it. Well, each one of these comes with their own consequences. If we're utilizing a drug that we're injecting, that could expose us to bloodborne pathogens, AIDS, hepatitis. If we are smoking a drug and it's a depressant, sometimes that could be safer because somebody might pass out and fall asleep before they get too much in their system that their body can't get it out. If you take a drug through your mouth, then your body has a natural response to try to help you in the case of an overdose. and that's where people throw up. The body's trying to get it out, just like when you're drinking in college and you threw up everywhere because you had too much alcohol in your system. So the different ways that it's used affects a few things. It affects how strong it is in your system. Obviously, injecting it right into your veins, it's the purest, and it bypasses a lot of stomach acids, and it makes it stronger. So overdose is, you're a lot more susceptible to overdose in that way. Another thing is the purity of it. A lot of opioids and opiates are either made illegally on the black market, and so drug dealers will cut the drug to make more of it. So different substances are weaker, even though you might be getting it from the same person. Every substance is probably weaker. And then also there's a lot of fake substances out there. So people will take fentanyl and they'll get a pill crusher and they'll compress a pill that might have, it'll look exactly like a Vicodin. And if you do like what I used to do when I would buy drugs, I would Google the pill and make sure that I'm getting what the person I'm buying it from is telling me I'm getting. Well, sometimes they're indistinguishable from one another. And fentanyl is a lot stronger than Vicodin is. So that's a lot of ways that people are overdosing nowadays, is just by getting a counterfeit drug. The next thing is there is a difference between a full agonist and a partial agonist. A full agonist essentially is a drug that fits perfectly inside of that little receptor cell. And so because it fits so perfectly, it's able to release a lot more endorphin, or a lot more of the feel-good chemicals, and it's stronger. A partial agonist fits to a little portion of that receptor. It doesn't fill it all the way. And so it releases a little bit of it releases less of those feel-good chemicals or endorphins compared to the full agonist. Well, this will be important when we talk about withdrawal later and medication-supported recovery, because anytime you have a full agonist versus a partial agonist, they compete for one another. And so in the case of medication-supported recovery, the partial agonist wins. And so somebody's not taking, so if somebody takes a drug like fentanyl, which is a full agonist, the partial agonist, the safer substance, such as buprenorphine, which is in Suboxone, that's going to be the substance that wins. And so that person isn't as likely to go into an overdose or get all the negative benefits of having, or the negative side effects of having fentanyl in their system. And just as an aside, if you all have heard of spice before, everybody's talking about how dangerous spice was. Spice is actually a full agonist, and that's what makes it so dangerous, is it's a full agonist on your anandamide or THC receptor. Regular marijuana, the reason why people aren't able to overdose on it is because it's a partial agonist. Just a little tidbit of information there. Let's get into probably one of the main reasons why people stay on opioid drugs, and this is withdrawal. As I said earlier, there's 3 different kinds of withdrawal people can experience. The first one, and the most commonly known one, is acute withdrawal. This is simply, I'm either reducing the substance that I'm taking, or I completely cut out the substance that I'm taking, and your brain goes into overdrive. Because opioids and opiates are a depressant, and that's in your brain for such a long time, when you quit taking it after you become dependent on it, your brain is highly stimulated. And what withdrawal can feel like is runny nose. Your skin is freezing, like you get hot sweat or cold sweats. So you're just sweating all over the place, but you're freezing and you can't stay warm. Restless leg syndrome. Your tears are flowing out of your face. You can't hold your bowels. So a lot of diarrhea, throwing up. And then finally, the thing that I think is the most crippling of all this is the insanity that you go through. If you're on a substance like methadone, as we talked about earlier, a fat-soluble substance, your acute withdrawal on that can last a really long time. It's not as severe as going on a different substance like heroin is, but it's really, really long. And It's actually so hardcore that the Nazis invented methadone. They invented it during World War II because there was trade cut off from the U.S. In Europe as part of war. They were cutting off the trade from Germany and Asia so that they didn't have any opioids for their troops in the field. And so the Nazis created methadone to be the substance that they use for anesthetics and for pain management. Well, the Nazis found that the withdrawal of this was so bad, so harsh to go through, that they would put it in POWs' food. And the POWs wouldn't realize that they were ingesting methadone. And then after a while, they would take it out of their food. And it would force their POWs to go through withdrawal as a means of torture. The next one is post-acute withdrawal. This is something that not a lot of people know about, and they should, especially if they're trying to get into recovery. This is more of a psychological withdrawal that can happen several months out, a few weeks to several months out from when you finished your acute withdrawal symptoms. So you might be feeling good, you're getting into recovery, you just got 60 days of recovery, you're feeling amazing, and then all of a sudden you're craving, you're having using dreams, you're not as happy as you used to be, life seems really dull. There might be anxiety, feeling like you need to use, otherwise you're gonna go into withdrawal. These are all symptoms of post-acute withdrawal syndrome, and this is your brain healing itself. It's experienced differently based off of the drug that you're on, just like regular withdrawal is, or acute withdrawal is. It all kind of depends on how you're using the drug, how long you're using the drug, what sort of drug it is, your own body's makeup. So there's no concrete criteria for how long your withdrawal could be or when your post-acute withdrawal will be. But it's good to know because it doesn't last that long typically. It could be a day or two, and then you're back into recovery again. And so this keeps a lot of people in relapse. They don't feel good about life and recovery, and they're like, well, just use again. If you're on a substance like methadone, those post-acute withdrawal symptoms, those can last over a year. That's really important to know because a lot of people are using methadone as their medication-supported recovery, and it's just good to know those sorts of things. The less known about withdrawal syndrome that people can experience, aside from acute and post-acute withdrawal, is something called precipitated withdrawal. And this is simply if you have that full agonist and that partial agonist competing for one another, or competing for the opioid receptor, or if you take something called an antagonist, which is essentially, it's called naloxone, and it was created for anesthesiologists to take somebody out of an opioid overdose during surgery. All it does is remove that opioid off of the opioid receptor, and it causes a very rapid, very violent withdrawal syndrome. And so in some cases, a person might have to go to the hospital for this. Opioid withdrawal is typically not deadly. A lot of people fear that it's one of the deadly ones. In most cases, people do not die from opioid withdrawal. They might feel like they want to die. It might be hell, but it's not something to be super concerned about somebody dying for. So now I want to kind of get into the specifics of different opioids that are out there. Obviously, there's heroin. And obviously there's different kinds of heroin, some from Mexico that they call black tar heroin, and then there's some from Asia. Another kind of opioid is pills and pharmaceuticals. And these are really important when we talk about the history of the opioid epidemic later. Another one is called fentanyl, which I'm sure you've heard about in the news. And what fentanyl is, as I talked about earlier, it can be absorbed through your skin. It's an extremely strong substance. Just a few grains of it is enough to kill somebody. And people are getting it from China and Mexico, and they're mixing it with different heroin, or they're making counterfeit pills out of it to make their drugs stronger or to make counterfeit drugs. It's a very deadly drug. The high doesn't last very long on it, but it's extremely strong. Another one is called carfentanil. This is a rhinoceros tranquilizer, believe it or not, that people are mixing with opioid substances. Literally less than a grain of salt of this substance is enough to kill a full-grown man or a full-grown person. It's extremely deadly. It's extremely toxic to the body. It's very strong, and people are mixing it with different substances to sell as counterfeit drugs or to make drugs stronger. Finally, there is a drug that I feel a lot of people need to know about because it's completely legal. You can buy it in gas stations all over the city. You can buy it in head shops all over the city. You can buy it at tea shops. You can buy it at smoking shops, like where you buy cigarettes. It's everywhere, and it's called kratom. Kratom is an opioid that's from Southeast Asia, and it's related to a coffee plant. I was addicted to kratom. This is a drug that people tout as not being addictive. They say that it's really good for you. It gets people out of opioid withdrawal, so a lot of people switch from heroin to kratom. And the bad thing about it, it's not very deadly. I should probably say that. There's not a lot of cases of people dying from this. However, the side effects from this can be horrendous. The withdrawal is like a normal opioid withdrawal, regardless of what the person selling it to you says. It's a unique substance because there are forms of it that can kind of speed you up. And if you take a little bit of it, it's almost like a stimulant. And then there's other forms that make you really sleepy. Or if you take a lot of them, they make you really sleepy. If you use this for a long time, it can cause psychosis. I went to the hospital for psychosis because of this drug. And I had to go to a doctor and seek medication-supported recovery to get off of this drug. It's not very well known about. There's a lot of misinformation on it, and people think that it's a miracle that can cure everything. And I would like to introduce Shauna. She's a friend of ours at SRC, and she has some experience with kratom as well, so I would like for you to listen to her story.
I did start shooting heroin up. I knew that one day, especially with my daughter, I knew one day I was gonna try my damnedest to recover. After my family found out, after I went to jail and came clean, I was still struggling with it. I didn't know how big this monster was. When I was desperate to get off of heroin, and I was looking up, just Googling things online, and I found kratom. So kratom wasn't really popular back then. Not a lot of people knew about it. And I started to dabble with that. But then it became I was using kratom just until I could, get my next use. Just, like one would use Suboxone or methadone, just to get to their next use. I don't think there was a lot of information online. It was an opiate-like, natural leaf, harmless, non-addictive. I couldn't use heroin. So I started using kratom. Even the natural things are not as innocent as you might think. Kratom actually ended up being one of the worst and probably the most detrimental things that I had done. Just what it's done to my stomach. Eating 60 grams of powder every day is not healthy. I would go days where I just literally was not hungry because I had so much powder in my system. My hair started falling out. Yeah, I started, it causes something called folliculitis, where your hair follicles, like you think you're breaking out, but you get these hard bumps. Really, really bad. Yeah. If abused, it can cause many, many ailments.
So how in the hell did we get here? A lot of people ask that. Why is opiates and opioids the thing that everybody talks about now? Why are we in the middle of this epidemic? A lot of us feel like it just randomly happened, but that's not the case. This has been something that has built up since the 80s and 90s. To get into the opioid epidemic, we first need to talk about culture, because a lot of this has to do with culture. So let's talk about pain. I'm sure not many people realize that pain, the experience of pain, is highly influenced by your culture. So pain is a private experience, right? But it's still influenced by social, cultural, and then psychological factors. The Aboriginals in Australia won't tell you about their pain unless if you ask. That's the way their culture is. In Nepal, people have access to modern day medicine. They have insurance or whatever. They have the resources to get into a doctor. All the doctors are just up to date as we are over here. But if they're having back pain, they won't go to a doctor for that back pain unless if it's debilitating. Over here, we go to doctors all the time for back pain. But in their culture, back pain is part of being old. It's just a process that you go through. In the 1800s, there was an author named Fanny Burney. And back then, we didn't really have anesthetics for surgery. This was kind of new to modern medicine, or the beginning of modern medicine and chemistry. And she was an author, and she went to a doctor because she had breast cancer. The doctor performed breast cancer on her without any breast cancer surgery on her without any anesthetic. While the doctor was cutting her open, she offered to hold her breast for him as he's removing the cancer from her breast, and she's completely lucid, awake, and feeling everything. Back then, the culture was, if you're a woman, you should be stoic, you should be strong, like you shouldn't complain about pain. Childbirth is just a part of life. Like that's what the culture was. In the 19th century, finally analgesics like opioids and anesthetics were discovered and starting to be utilized by doctors. Well, obviously, over the between the 1900s and the 2000s, we came up with a lot more and more medications. In the 1980s, there was the Wong-Baker Faces Pain Scale that was created. I'm sure you've seen it when you've been into the hospital at some point. And it's basically where you see the one face on one end that's all happy, and it's a 0 and smiling, big eyes. And then on the other end, there's a frowny face that's like crying. And one is a 0, the other one is a 10. This was created because sometimes little kids and children are unable to express what's going on for them. So they could point to the face. And people with language barriers could also do that. Like if they don't speak English and the doctor speaks English, they're able to kind of help diagnose what is going on. Well, fast forwarding a little bit, in 1996, there's an organization called the American Pain Society. And the American Pain Society was getting a lot of money from an organization called Purdue Pharma. They were paid $1 million by Purdue, and it was expected that they should advocate for some of the products that Purdue was producing. And so, since most people go to the doctor when they're in pain or in discomfort, that's pretty much the number one reason why people will go to the hospital or to the doctor. Well, the American Pain Society was trying to advocate for pain to be the 5th vital sign that every single doctor must go over with you as you're in the doctor's office. So to give you a little bit of context to that, the other vital signs include like your heart rate, your blood pressure, your temperature, your pulse ox, the things that keep you alive. But pain is supposed to be just as important as those are. So we started creating a culture where every time you go to the doctor, I'm in pain, the doctor has medication for that. Purdue also wanted to become, I want to put this in quotations for you, the end-to-end pain provider. So Purdue created a drug called OxyContin. And OxyContin is essentially the same thing as heroin is. It's just released over time. And as people were taking OxyContin, a lot of them were overdosing just off of one pill because the pills were so strong that they were first creating. Purdue decided, you know what, why don't we try to create drugs for the other things that these drugs are causing? Because they were realizing that people were becoming dependent on it. They were becoming addicted to it. And they created an operation called Project Tango. They gave it, that sounds like a CIA name, right? Well, it is kind of a CIA name. It was their operation that they didn't want you to know about, so it's Tango. Well, the idea behind this was to create a medication for every single negative side effect that maybe these opioids are creating. So they came out with something called buprenorphine, which is Suboxone, and that's medication-assisted treatment that we use. It works very well. They decided, let's release this too, because once somebody becomes addicted to our OxyContin, we'll get them addicted to that, or we'll get them on that to take them off of the OxyContin. They decided, let's create really expensive devices that can administer naloxone in case if somebody's in an overdose. So they created that. They started getting money at every single avenue that you could go down off of going to the doctor that they tried to advocate, pain being the fifth vital sign for. So essentially you have a culture created around medication, created around opioids, and that's just what we live with now. So that's a big reason why you're seeing this opioid epidemic. It all kind of starts with Big Pharma and the different things that they were doing behind the scenes. So I would like to introduce you to another person that's with SRC, and his name is Bob. And I would like you to listen to Bob's story of how pain medication affected his life from having a bad back.
I have a lot of experience with opiates. I was doing intense labor when I was like 14 years old and started screwing my body up then. And then through my drinking and growing up, I had several severe car accidents, and I finally had to deal with the surgery and had a complete front and back fusion, 3 levels. At that point, I of course had opiates for what they were for, which is immediate intense pain, and they worked. And after the surgery, my surgery was successful. After the surgery, I did stop the drugs and managed to get off of them, but that only lasted for about a year and a half. And then my pain was getting worse all the time, emotional pain and physical pain. So I went to a pain management doctor who basically gave me permission to, oh yeah, with the surgery that you had and everything, you're screwed up for life. So, you're gonna have to be on something for your whole life. You're not gonna get rid of your pain. The only things they ever did was and it happened a few times to me, they would make you go and try the shots in your back to see if those would work. And then that would authorize them that, oh, the shots didn't help, so we're gonna keep you on opiates. And then as it progressed, I took more and more prescription medications. They gave me more different prescription medications, and they raised my other opiates so that they could see how much my tolerance was. They wanted to push the envelope as far as possible. After using them for a while, you realize that, this isn't just addressing my physical pain. It's much more, it's making me feel better. And it's just a constant cycle. It just keeps getting worse and worse. I spent a lot of time, finally going back to the street so you could get supplement drugs and different kinds of drugs. By the end of my opiate use, I was between doctors and the street, I was on 9 different medications.
As I talked about earlier, Purdue created all these different substances to help with the opioid epidemic that they were involved in trying to create in the first place under Project Tango. But I would like to talk about those substances because regardless of how you may feel or I may feel or whatever emotions that brings up with you thinking about what happened with all of that, there are a lot of benefits to some of these. So the first one is a drug called buprenorphine, and this is one of those partial agonists that I talked about earlier. It's fat soluble, It's long acting. It does have a long withdrawal, but because it's a partial agonist, it's not near as strong as a full agonist like methadone or heroin or whatever would be. And so when you go through a withdrawal on it, the withdrawal isn't near as severe as one of those would be. And it comes in many forms. Thank God it's covered by Medicaid now. So if you have a client or know somebody that's on Medicaid, they have access to this medication. So essentially you would have to be in withdrawal from the drug or substance you're dependent upon before you take buprenorphine or Suboxone, because it will cause that precipitated withdrawal syndrome that I talked about earlier. Depending on the substance that you might be on, like if you're on methadone, you could have to wait 3 to 5 days. If you're on a different substance like heroin, it's 12 hours. The doctors will give you some medications to make you comfortable, like blood pressure medication or something to help with your anxiety as you go through that process. Then you could take buprenorphine. It is a sublingual medication, so it comes in little tablets or film that you put under your tongue and you let it dissolve, and then it goes into your system and it fills those opioid receptors with a partial agonist, so it's not as strong as the other ones are. While you're on it, since it's filled in those receptors and it competes with full agonists and it wins in that competition, if somebody tried to relapse on another drug, it's not possible. It also releases a little bit of endorphins to the point that it brings people out of the withdrawal that they're in when they go to the doctor in the first place. So it takes you out of withdrawal. You're in seeing your doctor for a while. A lot of people are on these drugs for 1 year to 2 years, and then they're out building up their life. They're getting into recovery. They're setting up different resources and different capital to rely upon for when they're off of the Suboxone eventually. And then it's kind of a softer, smoother way for somebody to transition into recovery. Suboxone is a drug that is sold on the streets. It's sold for a lot of money. People can get high on this drug, especially people that aren't used to taking opiates. They could get really high on this substance. What's unique about this, though, is the different forms that it's in nowadays. There is a thing called Sublocade. And what this is it's a shot that the doctor will give you. Sublocade lasts for a month, even longer as you're going through like a taper process off of that month. But it's active in your system for a month, so it's not abusable. It's not something you could sell on the street. Sublocade is readily available. There's a few organizations that I really respect. Another form of it is called Probufene, but it's essentially like the birth control rod that women get under their skin. You can get one of those implanted under your skin. It costs like $6,000. Medicaid doesn't cover it, but that one lasts for 6 months. Another thing about buprenorphine or Suboxone is doctors have to be registered, I believe, with the DEA in order to prescribe it. So not just any doctor is able to prescribe it. I caution you to research a good doctor to prescribe it. I have been on Suboxone several times in my life, and I've received it from a total of 4 different doctors. The first doctor was really bad. My insurance paid for everything. Essentially, I was abusing it and then getting high on days when I didn't have methadone. I'd go on Suboxone so I didn't feel withdrawal. I got on a really good doctor a few years ago, but he retired and I went to another doctor. The new doctor that I was at didn't accept insurance. She accepted cash or Zelle. I had to pay her cash or use my phone to give her Zelle money. When my doctor retired that I was seeing originally, all of his patients had to go to different doctors in the city. And my therapist in town, she had quite a few clients that were going to that doctor that retired. And there was probably about, I believe, 5 of us that went to this horrible doctor that I had this experience with. After the end of the month, of 1 month of him being retired and all of us going to her, there were 2 of us left. 3 people had dropped out and went back on heroin. The other person was trying to get off of Suboxone. You could withdraw from it, so you need to go through a taper process. And he was on 2 milligrams, which isn't a lot. He was almost completely done with his treatment. She talked him into going back up to 16 milligrams, which is a lot compared to where he was at. I was at 6 milligrams, and she tried to get me to go up on the medication. And this lady would hold on to my prescription until I went to an ATM to get money to pay her for her services. So be very careful about what doctor you go to. If they accept insurance, that's probably a good sign that you're seeing the right person. There's a reason that the DEA kind of covers a lot of these things, because some of these doctors don't have the best intentions when it comes to their patient care. And a lot of Suboxone doctors require their people to be in recovery. They require them to have a therapist, to take UAs, to do all the things that they need to do to finally get off of this drug and live a healthy, happy life again. Another drug out there is methadone, which we've all heard about before. There's methadone clinics that people can go to, and people have success with it. It can be abusable. It's not a partial agonist, it's a full agonist, and the withdrawal process on it is very long. As I talked about earlier, it's fat soluble. For me, it was my drug of choice. I was able to get really high on it because it's not that partial agonist that something like Suboxone would be. Another drug, which is an antagonist, is called naloxone. I talked about this a little bit earlier when we talked about precipitated withdrawals. And we'll talk about naloxone when we go into opioid overdoses. This comes in many forms as well. There is a shot that you can get called Vivitrol. And essentially it's an injection that you get once a month. And it's in your system for that entire month. And so if you were on an opioid, when you take it, it would obviously pull it off of the receptor because it's an antagonist. However, if it's just in your system, you can't get high or use any opioids while you're on it. It will disallow them from being able to fill that receptor. This is not something that's abusable. It's very benign. There are no, it doesn't affect your psyche at all. It's just like you go in and get a shot and it just lasts. Vivitrol is very expensive, and certain insurances won't cover it. However, you can get naloxone hydrochloride in a pill. Not a lot of people know about that. And in that pill, it lasts for about a day, day and a half. So you just have to have somebody that makes sure that you're taking your medication so that you don't forget to take it or decide not to take it and then get high. But that's a good way that people get into recovery, is through naloxone. Finally, I want to get into this idea of harm reduction. As we know, opioids are super deadly in various ways. As we talked about earlier, depending on the way you use an opiate or an opioid, you could end up with HIV. You could end up with hepatitis C. You could end up with so many different bloodborne pathogens. The idea behind harm reduction is to try to take out at least some of the harm that we can, so that these things aren't as deadly or aren't as harmful as they are, depending on how people use it. So in Colorado Springs, we don't have one, but in Denver, there's a tremendous organization called the Harm Reduction Action Center. I had a bias towards these people, or towards this place originally. I'm like, it's a needle exchange. You're encouraging people to use drugs. But then I went there and I talked to them. And their mantra that they say there is, dead addicts don't recover. Yes, they supply needles. They teach people how to effectively and safely use their drugs. They give out everything that you would need to shoot up a drug except for the drug itself. But they also give fentanyl testing kits for free. So people can test their heroin to make sure of the purity of it, make sure that there's not fentanyl in it so they don't have an overdose. They give out Narcan. They give out resources for food, for clothing. They give out education on how to get into recovery. They try to help people get into recovery. They try to do as much as they can while people are safely there to get them into a place where maybe they're like, you know what, I don't want to use this drug anymore. I need help. And they try to bring them to the correct resource to help them. The next portion of this harm reduction is a little training that I want to do for you, and it's how to bring people out of an overdose. So what is an overdose? An overdose is somebody's inability to tolerate an opiate. There's different factors involved in that. It could be how tired you are, if you're sick, if you're mixing substances. There's so many different things that can cause it. First thing to avoid being in an overdose is to test your substance before you use it. If you have a fentanyl testing strip, that's a good thing to do. They recommend taking a little bit of the substance before taking enough to get you the high that you might want, so that you can tell, like, maybe this is mixed with something that's going to get me way higher than I thought I would be. In Denver, a long time ago, there was some police that were buying heroin at this same park over the course of a week, and they were testing it. And they bought from the exact same dealer every time. They found the heroin to be anywhere from 8% impurity all the way up to 60% impurity over the course of a week from the same dealer paying the same price. So it all kind of depends on the drug that you're getting each time you do it. The other thing is, don't use alone. Make sure that you have Narcan, which we're going to teach you how to use in a second. Make sure that your door is unlocked so that somebody can come find you if you're in the house with somebody else. And not mixing substances. If you were to mix a substance, make sure that you use the opioid first, as opposed to using something like a benzodiazepine or drinking before you mix your Jack Daniels and your heroin. And the reason why that is because a lot of the other drugs that you can take mess with your decision-making process, and it might cause you to think that maybe taking more than you should is a good idea. That's why people get drunk and drive. It's stupid to do, but they do it. However, if you take an opioid first, it doesn't mess with those decision-making processes as much as the other drugs do. So they say use that first and then maybe try the other ones, and it won't cause such a problem for you. So let's get into how to take somebody out of an overdose. As we talked about earlier, an overdose is simply somebody's inability to tolerate an opioid that they might have in their system. This could be caused by either having too much of an opioid, being clean for a while and then using again, so being abstinent for a little bit and then their tolerance lowering. It could be caused by being sleepy, being sick, maybe getting a drug that's tainted with something like fentanyl, as we talked about earlier, or even if you mix substances. Sometimes people think that if they use something like methamphetamine with heroin, since they're two completely different ends of the spectrum, one being an upper and the other one being more of a depressant, they think that they won't interfere with each other. However, the opposite is true. That could cause somebody to go into an overdose. So how you get somebody out of an overdose is, first, you got to acknowledge that they're in an overdose. What that looks like is when somebody's in an overdose, they start suffocating. And so they'll have bluish lips, they'll be unresponsive, most likely they'll have a very shallow pulse or no pulse if they're dead. And so what you would do to try to wake them up from that is, first, you could take your fingers like this, take your hand and make a fist, and rub on your chest really hard. That's called a sternum rub. Another thing that you could do to try to wake them up is a trap pinch. So basically you take and you pinch their trapezoid up here really hard. And that's another technique that you could use to try to wake somebody up. Also, talking loudly. So if I came in the room, and this is our dummy, his name is Smoke, first thing I would do is talk loud, and I'd be like, Smoke, Smoke, wake up. If he doesn't wake up, I'm going to start rubbing on his sternum, start pinching his trap, trying to see if I could get him to start waking up. The next thing that I will use is Narcan. Narcan, as we talked about earlier, is an antagonist. So what this is going to do is it's going to go inside his system and it's going to pull that opioid off of that opioid receptor. It was invented in the 60s by an anesthesiologist to take people out of overdoses during surgery. So you pop this open, and this form of Narcan is it's a nasal spray, much like your common Afrin or whatever other nasal sprays you might see at the pharmacy. So you open it up. There is no lid on it, so it's easily accessible. And you take and you just squirt it into the nostril. Narcan takes about 3 minutes to start kicking in. So if somebody is not breathing during that time, they could still suffocate while you're waiting for the Narcan to start working. So you could do a thing called rescue breathing. Now, with rescue breathing, the first thing you'll want to do is you want to stick your fingers in the mouth. Sometimes people regurgitate when they're in an overdose, so you want to stick your finger in the mouth and try to clear out the airway, because if there is some sort of debris or object in there, you're going to blow that into the lungs. So you would turn somebody over, pull it out, then you would pinch the nostrils, grab by the chin, pull up, and you give 2 really deep breaths at first, really deep, strong breaths. So now, after that, you have 6 seconds before you need to give another deep breath. So 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6 1,000. You breathe again. During that time, while you have Narcan on board, you're going to want to call 911. If somebody's in the room with you, obviously have them call 911 while you're rescue breathing. But if they're not there, I encourage you to use speakerphone. Now, when you talk with 911, to make things simple, just tell them your name, the location that you're at, and tell them somebody is not breathing and you need emergency services. If you say somebody's in an overdose or something like that, it could complicate the issue, bringing police and other people there. Just simply say that somebody's not breathing, tell them that you're rescue breathing for them so that they don't try to ask you too many questions and distract you while you're waiting for this person to wake up. So after you give somebody Narcan, Narcan has a 30-minute half-life. As we talked about earlier, a half-life is essentially how long the drug is able to work. So after 30 minutes, if he still has a ton of opioids in his system, he could fall back into that overdose again. So it's imperative that you get somebody into the hospital. When Narcan starts working on the system and relieves that opioid, people have different responses depending on how much of the opiates are in their system, how long they've been using, what have you. When we talked about precipitated withdrawal syndrome earlier, that's essentially what Narcan could do to people. It's pretty shocking. You could see somebody that's essentially passed out and unresponsive, and they'll wake up and start talking to you. Sometimes they'll defecate themselves. Sometimes they'll be really sick. Sometimes they'll be just a little bit sleepy and groggy. It all depends on how many opioids are in their system and how strong those opioids are, which brings me to my next point. This Narcan is 4 milligrams. The fentanyl and the carfentanil and the different things that are being mixed with heroin nowadays, sometimes Narcan's not strong enough to take somebody out of that. You only have in these boxes a total of 8 milligrams. So if somebody is not waking up within 2 to 3 minutes, administer another dose. If they do wake up, like, I encourage you to wait the 2 to 3 minutes, because if it takes a while for emergency services to get there, you still have a second shot of Narcan that you could give somebody if they happen to fall back into that overdose. So Narcan is part of the Good Samaritan law now, and it's a very benign substance. You could essentially give this to an infant and it wouldn't do anything to them. So you're protected. If you think that somebody's in an overdose, give them Narcan. If they're on a bunch of different substances, let's say that they're on methamphetamine and they're on heroin and fentanyl and they drink as well, at least you're taking that opioid out of the equation from that concoction that's in their body. In conclusion, we talked about what Narcan is, how to recognize if somebody's in an overdose, what sort of signs they're showing. We talked about the sternum rub and the trap pinch and speaking loudly to them. We talked about administering Narcan, at least the nasal Narcan. There's other kinds that you can give an injection for. We talked about the steps to rescue breathing, which is clearing the airway, pinching the nose, moving the head up, grabbing them by the chin, giving the breath, 2 deep breaths, and then every 6 seconds giving another breath. We talked about how long Narcan lasts in your system, calling 911 and getting them to emergency services, and then finally the Good Samaritan Act. And one final thing, under that Good Samaritan Act, there was a problem many years ago where if somebody was in an overdose, they would just drop them off at the hospital and then leave, and a lot of people were dying. So now, the way it is, if the person that is rescue breathing or administering Narcan who called 911, they are completely free and clear of any legal issues if the cops show up and there's heroin in the house or whatever, and so is the victim as well, to encourage people to call 911. This is all part of harm reduction, and the idea behind harm reduction is dead addicts don't recover. And so, I mean, people are going to hit their bottom as it is using these type of drugs, but if we can at least try to save them, they have a chance at recovery. All of this information, it might sound kind of clinical or like a doctor's talking about it or something, but the reason that I bring all these things up is because you should probably know about them. It's good for parents to know about them, or if you work at a treatment center, it's good to know about these things so that you can best help either yourself, somebody else, or somebody that you love. I learned about all this stuff because I made a bunch of stupid mistakes. And I think that sometimes fools end up becoming wise. And that's what happened with me. So I want to thank you for watching this. I appreciate your time. If you need anything from Springs Recovery Connection, if you want a training or something, please give us a call. I would like to thank Bob. I would like to thank Shauna for being so real in this video and for telling their story. And I would like to thank Tim for making this video. And thank you again for watching this.